When you get a diagnosis of lupus, you are in the very beginning of a journey of education and self-discovery. To truly thrive with your condition, you're going to need to become an expert in your lupus, which means you'll need to understand the tools and the markers that your rheumatologist uses. Your symptoms will forever and always be the North Star guiding decisions. But we do use a lot of blood tests, and understanding those blood tests will give you a head start on your own journey. So I've compiled my top videos on all the tests that we use to diagnose and better understand lupus. I cover the ANA, the anti-double-stranded DNA, the anti-Smith antibody, complements, and the anti-histone antibody, all while taking these tests and putting them in context with how you actually feel. We get into the details, so make sure to bookmark and save this video so you can return to it anytime you need a refresher. I'm Dr. Elizabeth Ortiz, and this is Connected Rheumatology. Let's get started. So today I wanted to talk about the 5 things you need to know about your positive ANA blood test. All right, so number 1, it's just a test. It is not your destiny. Antibody tests, specifically the ANA, anti-nuclear antibody test, is really a broad term that we use to describe a collection of different autoantibodies, meaning that there's a lot of different types of ANA. Some of them we understand, we can test for, and we know are associated with particular conditions, but others not so much. And all this to say is that the ANA test is very non-specific. Just because you have an ANA does not mean you're destined to develop anything. Number 2, the ANA does not cause lupus. Now, one of the reasons many people freak out and think that a positive ANA test definitely means they have lupus is the idea that this autoantibody causes lupus. And although there is some interesting research coming out that might give us a more complete picture of what's happening, for the most part, the feeling amongst rheumatologists is that it does not cause the disease. In fact, some studies showed that you can take ANA-rich blood from someone and transfuse it into someone who doesn't have an ANA, and that person doesn't develop any kind of autoimmune condition. Number 3. A positive ANA test is seen in a lot of different conditions. Now, we often associate it with lupus, otherwise known as SLE or systemic lupus erythematosus, but the truth is an ANA is so nonspecific it can be seen in a lot of different conditions. So you think about your autoimmune conditions, we think about rheumatoid arthritis, scleroderma, Sjogren's syndrome, but it can also be seen in non-autoimmune conditions, so different types of infections or even cancers. A positive ANA is definitely a clue, but it certainly doesn't solve the mystery, and many times it can actually make things more confusing. Number 4, as if things weren't complicated enough, the ANA can be seen in people who have absolutely nothing. And about 20 to 30% of the population can have a positive ANA blood test and not have, nor ever develop, an autoimmune condition. Again, just another reason not to sound the alarm. I often say it's my job to figure out if that ANA means anything. If you have a positive blood test, I absolutely think it needs to be investigated. But my job is to start from the top and work our way down and see if there's any other clues that might tell us that that positive blood test actually should be taken seriously. And number 5, for the most part, once you have an ANA test result and a determination has been made, you don't really need to repeat that test. Now, I know this one might be a little controversial, especially amongst my rheumatology colleagues. Once a determination has been made, you don't really need to repeat the test. So let's say you have a positive ANA blood test and you see the physician and the doctor tells you that you have lupus. You start treatment and you're seeing that doctor on a regular basis and you're getting regular labs. You might assume that in those labs we are repeating the ANA, but honestly we're not. But we have a lot of other markers that we check, most importantly being talking to you and asking how you feel, that help us determine if we need to change medicines or what's going on. And the opposite is true. If you have a positive ANA result, but it's been determined it doesn't mean anything and you don't have an autoimmune condition, there's really no reason to repeat it unless your symptoms change. Some people think that adding the ANA test to their regular checkup labs will somehow give them more information, and quite honestly, it doesn't. Having your ANA checked just on a regular basis for no reason doesn't tell anyone anything. So the ANA, or anti-nuclear antibody, is a blood test that is done to screen for autoimmune conditions. So when you go to your doctor and they have some concerns about you having an autoimmune condition, either based on the symptoms you are having or maybe some other abnormal blood test that popped up in your routine test, they will typically check an ANA. But as I've talked about before, the results of the ANA test are not black and white, and a positive result does not automatically mean you have an autoimmune condition, and a negative result doesn't automatically mean you don't. The results of the ANA are always taken in context of what other medical conditions you have and what your symptoms are. And the result itself can sometimes be used to help figure out how to interpret it. Now, ANA tests come in different varieties, meaning the lab has different ways of detecting whether your blood has anti-nuclear antibodies. Each method has pros and cons, and getting into the specifics of the way the tests are run, it's not really what I'm here to do. But just know that the ANA test is not an ANA test, is not an ANA test. Just understanding this can provide some useful information when attempting to interpret repeated ANA tests you may have had over the years. It's not uncommon to have had ANA tests in the emergency room, which will then be using the hospital's lab. Then years later, done in a primary care doc's office, which may use one of the major lab companies. And then again in a rheumatologist or other specialist office. Now, I have often faced questions and, to be honest, a little anger from people confused and frustrated that a positive ANA result from a few years ago is not being given enough attention by their current doctors. It's tough because two things are true. The presence of an ANA can come and go over time, both in those with and without autoimmune disease. And two, the way the test is actually conducted in the lab can influence if a result is positive or negative. This is why we still rely so heavily on your symptoms and other lab tests. So now that that is out of the way, let's get into what you really came here to learn, which is, what does the pattern that is reported with your ANA result mean? So when your ANA is done via immunofluorescence, or IFA, which, by the way, is considered the gold standard method of checking an ANA, it is reported back as a titer and a pattern. It is not simply a positive or negative, and it is not simply a number. Now, the titer can be reported as 1 to 80 or 1 to 1280 and everything in between. Now, usually, the higher the titer, the more suspicious for actually indicating autoimmunity, but this is highly variable. So take that statement with a big chunk of salt. The pattern that is reported is based on what the cells look like under a microscope after a special dye has been applied. As of this recording, 29 different pattern types have been identified, but honestly, there are only about 5 or 6 that are commonly reported. Now, just a side note, even reporting of the patterns has variability, as this is mainly done by humans. But that's likely to change as AI solutions can identify patterns with more consistency. Also, keep in mind that the identification of the 29 patterns and what conditions they are associated with is new. The International Consensus of ANA Patterns, or ICAP, has only recently structured their findings, and it takes a while for information like this to go from a paper to actual practice. All right, so homogeneous. Now, the homogeneous pattern can also be called nuclear homogeneous, and it's called this because when the dye is applied, it spreads out homogeneously over the entire nucleus. Now, this can be associated with lupus, autoimmune hepatitis, which is liver inflammation due to autoimmunity, or juvenile idiopathic arthritis, which is an RA-like condition that can happen in kids. Now, lupus, autoimmune hepatitis, and JIA are very different conditions. So when this result comes, the next step is about determining which of those conditions I'm most concerned about and then chasing that one with more questions and more tests. The next pattern is speckled. Now, the new nomenclature now separates out different types of speckled into nuclear large core speckled, nuclear fine speckled, nuclear dense fine speckled. I'm going to hold on the nuclear dense fine speckled as that one deserves some special attention. But nuclear fine speckled and nuclear coarse large speckled can be associated with things like lupus, Sjogren's, dermatomyositis, and scleroderma. Again, these are all very different conditions, and the next step of questioning and testing is really reliant on what any particular person's symptoms are. Now, a word on dense fine speckled. I wanted to highlight this because we are more and more recognizing that this staining pattern has a negative association with autoimmune conditions, meaning the presence of this pattern points against the presence of an autoimmune condition. Now, to be fair, this statement is only true if the staining is due to an autoantibody against DFS70, which is a test not every lab will run. Now, it is not uncommon for a rheumatologist to get a consult for someone with a positive ANA, and the pattern is dense fine speckled. This will automatically lower the concern for something like lupus, but of course, as we always say, it still depends on your symptom. I wanted to pay special attention to this pattern to point out two things. One, a positive ANA result does not automatically diagnose anyone with anything. And two, our body is always making autoantibodies, and simply finding the presence of an autoantibody in a lab test does not mean there's disease. The next pattern is centromere. Now, this staining pattern is strongly correlated with the presence of an anti-centromere antibody, which is a whole different antibody test in and of itself. And it's associated with the development of a condition called limited scleroderma, or CREST syndrome. Now, CREST syndrome is very different than lupus and will put someone on a different path if this is what the diagnosis is. Then finally, we have the cytoplasmic pattern. Now, this is now understood to be a variety of different staining patterns that we used to put under one umbrella that we call cytoplasmic. For those observant biology lovers, you may be confused. I thought ANA stood for anti-nuclear antibody, meaning this test was looking for antibodies against stuff in the cell's nucleus, not the cytoplasm. Okay, now remember, our cells have lots of different parts. The nucleus, which is the heart and brain of the cell, and then the cytoplasm, which is like, the goo of the cell. Dear God, please don't come after me for calling cytoplasm goo. Something in medicine wasn't 100% accurate. Shocker, I know. We now know that these types of autoantibodies, and more specifically, these types of antibody tests, can find autoantibodies against stuff that live in the goo, not just the nucleus. Okay, so what does cytoplasmic pattern mean? Well, depending on how specific your lab is going to be, it can be associated with hepatitis, hepatitis C, lupus, myositis, or mean nothing at all. So what do we make of all of this? I know that this has been a lot of technical and biological information. I know. But the key point I wanted to try to make was that the science of the ANA test is still changing. It is becoming more refined, but these changes and insights are not brought into the clinic overnight. It would be lovely if this test result could be as black and white as the ink and paper it's printed on, and could give us definitive answers to the "what is wrong with me" question. But the ANA test simply can't. It's a test we use to guide us and point us in a direction, but next steps will always mean asking more questions and running more tests. So think, when you've had your ANA tested, was it reported as a single number or as a titer and pattern? If it was reported as a single number or simply a positive or negative, do your symptoms warrant repeating the test, but this time using the immunofluorescence technique to get a more specific result? Now, when interpreting ANA results, context is everything. To help your doc have more information, come with the answers to the following questions. What have your symptoms been for the 3 months prior to your ANA test? I want you to rank them in order of frequency, starting with your daily symptoms and ending with your every blue moon symptoms. Did you get diagnosed with any other medical condition 3 months prior to your testing? Did you start any new medications or supplements prior to your testing? All right, folks, that's what you need to know about ANA patterns. If you really want to go down a rabbit hole and be inundated with specific antibodies and possible associations, you can check out ANApatterns.org, but be warned, Your doc, even your rheumatologist, may not be up to speed on the details of all 29 patterns, as this is all new nomenclature and details and associations are still being worked out. So the dsDNA, or double-stranded DNA, is an antibody that is commonly checked either with the ANA antibody or immediately after a positive ANA antibody result is received. And it really depends on what kind of test your doctor orders. There are various autoimmune or lupus panels that your doctor can order that will include not only the ANA, but a lot of other antibodies. And one of those other antibodies that is always included in those panels is the double-stranded DNA, or DS. So here's some answers to the top 5 questions I always get about a positive dsDNA result. Number 1. What is it? What is the double-stranded DNA antibody? Well, kind of just like it sounds, it is an autoantibody. Auto meaning it is an antibody against the self that, in this particular case, is against the genetic material that's found within our cells. So the genetic material, you might remember from high school biology, is DNA. And we have single-strand DNA and we have double-stranded DNA. And so this particular antibody is against the double-stranded DNA material that we find in our nucleus. If you remember from the previous video, the antibody term ANA actually refers to a collection of autoantibodies. And one of those autoantibodies that falls under the umbrella of ANA is the double-stranded DNA. And it's for this reason that it's very, very rare for someone to have a positive double-stranded DNA result after having a negative ANA result. Does that make sense? Because if you have a positive ANA result, what the further testing is looking to see, well, which type of ANAs are there? So it would be highly unusual, not completely impossible, but highly unusual for someone to have a positive double-stranded DNA result after having a negative ANA result. All right. Number 2, what condition is the double-stranded DNA antibody related to? Now, you'll remember that I spoke about the rheumatoid factor and the ANA antibodies and how they're pretty nonspecific, and how you can see the presence of those antibodies in blood tests in people who either have no health problems or have other conditions aside from rheumatoid arthritis or lupus. With double-stranded DNA, it's a little different. Now, of course, everyone's unique, and there are certainly cases where the double-stranded DNA result has come back positive in people who don't have anything. Usually the results in those cases will be very low or borderline, but in general, the presence of a double-stranded DNA antibody, especially a moderately or high titer of the double-stranded DNA antibody, does indicate the presence of lupus. It is very closely tied to lupus. Now, you can also see it in conditions such as Sjogren's syndrome and scleroderma, which I talked about a few weeks ago, so if you missed that, I'll put it in the link below. But even in those conditions, I would argue that if someone comes back with a double-stranded DNA antibody level that's reasonably high, that the doctor needs to take a second look and see if any of the features that Sjogren's patient or scleroderma patient is exhibiting, could they be features of lupus? There are times where people can have more than one autoimmune disease. But the point I want to make is that the presence of a double-stranded DNA definitely will make a rheumatologist raise an eyebrow and make them think along the lines of lupus. Okay, number, what are we on? 3. Why is the double-stranded DNA antibody more specific than lupus? All right, well, yet again, I'm going to refer to what we talked about with the rheumatoid factor and the ANA. And we talked about how one of the reasons you can see these positive blood tests, the rheumatoid factor and ANA, in individuals who don't have any disease is because there's no data that shows us that those particular autoantibodies cause rheumatoid arthritis or lupus. It's a little different when we're talking about double-strand DNA. Research has come out that shows that the actual antibody to the double-strand DNA is involved in the development of lupus, most specifically in the development of kidney disease within lupus. Now, it's certainly not 100%. I just said that you can have low or borderline results for double-strand DNA in people who do not have lupus. But in general, when someone has lupus and they have a moderately to high level of double-stranded DNA in their serum, in their blood, then the doctor then has to be on high alert for kidney disease, because the data is showing that that antibody can actually be involved in creating the kidney disease. All right, number 4. Do I need to have my double-stranded DNA antibody level repeated? What we know with lupus patients in particular who have a double-strand DNA in their blood test is that the titer, the level, will go up when someone's lupus is active, and it will go down when someone's lupus has quieted down. So it goes up with lupus disease activity and it goes down with lupus disease activity. And so yes, we repeat it. When a lupus patient gets blood work done every 2 to 3 months, one of the tests they have done is that double-stranded DNA. Now, even though the textbooks teach us this, patients aren't textbooks, and there will always be individuals who bust or break through that so-called rule. And there are patients who by every measure are doing well, but yet will still have a positive double-stranded DNA level in their blood work. And vice versa. There can be patients in a very severe flare who, when you check their double-stranded DNA level, it might be negative. With time, the doctor and the patient can better understand how reliable their double-stranded DNA result is in predicting and in telling us what's going on inside. In some cases, it's very reliable, and in other cases, it's not. All right, so then now we're at number 5, the number 5 question with a little bit of a bonus question. Well, if I have an elevated or high double-strand DNA level, do I need to change or increase my medications? And bonus question, are there any natural ways of lowering my double-stranded DNA level? The first question is a little nuanced and possibly even a little controversial. You will find individuals who will suggest or recommend changing your medication or increasing your medication because your double-strand DNA level is elevated, and so that must mean that you have some lupus still active within your body. There are other individuals who take a more nuanced approach, and that's the way I like to do it. If someone is doing well, but yet still continues to have a very high double-strand DNA level, it does make me search a little harder for where is the lupus? What does this mean? But the reason I believe this requires a conversation is because the medications at our disposal that we use in lupus patients and that we use to try to get lupus under control are not without side effects, and they are not without risk. Now, these conversations take time, and I know that's one thing we don't all have when we're with our doctor. You know, these quick appointments we get don't always allow us to have some of these conversations. So I would recommend when you go to see your doctor, if you find yourself in this position, to ask them, what do you think of my elevated double-strand DNA? Do you think we should treat it? If we do treat it, what are some of the pros and cons and risks that might come from those treatments? And then together, y'all can make that decision. And then the bonus question about, is there anything natural that will lower my double-strand DNA? You know, nothing that's been proven. Now, I am a big proponent of investigating other options. I don't think, as rheumatologists, we have all the answers, and I think to assume we do is arrogant. That being said, the double-strand DNA is associated specifically with kidney disease. And if someone were to opt for only a natural approach to lowering that double-stranded DNA, it is inviting the risk that you have under or untreated inflammation in the kidneys that can then lead to permanent, irreversible kidney damage. And I don't think any of us want to be dealing with that. Today we're going to be talking about another commonly tested autoantibody, the anti-Smith antibody, or anti-SM is how it's listed on your lab report. This is an autoantibody commonly checked when someone has a positive ANA, and it can lead to a lot of confusion and anxiety. So we're going to talk about all things anti-Smith today. So let's just start at the beginning. What is an anti-Smith antibody? Well, the anti-Smith antibody is an antibody whose target is the Smith antigen. And the Smith antigen, when I use that word antigen, antigen is just the protein that's found within your body that is the target of the antibody. So remember, every antibody is specific to a target, and we call that target the antigen. So the Smith antigen is found within the nucleus of our cells. So it is a nuclear antigen. Hence, the Smith antibody is an anti-nuclear antibody. So it's one of those ANAs. Now, the Smith antigen was discovered in the 60s. And it was found pretty much from the beginning to be pretty specific for lupus. But that doesn't mean everyone with lupus will have this antibody. In fact, only about 25% of lupus patients will have an anti-Smith antibody. When it was discovered and it was found to be so specific with lupus, the American College of Rheumatology actually included the presence of an anti-Smith antibody in their long list of criteria that they put together to help doctors make a lupus diagnosis. Shortly after the discovery of the anti-Smith antibody, they discovered the anti-RNP, the anti-SSA, anti-SSB, and a whole slew of other nuclear antigens that are the targets for various different autoantibodies. So it really was the first one that kind of kick-started this discovery and understanding of genetic material and molecular biology. So it really was like a big deal. So why do we call it anti-Smith? Well, it's really an old-fashioned remnant of the way we used to label things when we discover. So they used to label them oftentimes after the patient in which it was discovered. And so the anti-Smith antigen and anti-Smith antibody was discovered in the blood of a lupus patient by the name of Miss Stephanie Smith. Now, Miss Smith was diagnosed with lupus in 1959 at the age of 15, and she was being cared for at the Rockefeller University in New York City. Unfortunately, she had a lot of complications from lupus and succumbed to lupus at the age of 22. Now, her treating physician, Dr. Eng Tan, who was also one of the scientists to discover the anti-Smith antibody, has noted that she was a very talented painter and has actually published one of the paintings that he has in his possession. He is currently a professor emeritus at Scripps Research, and I really just bring this up just to highlight that this discovery was not very long ago, and our knowledge of autoantibodies and specifically autonuclear antibodies and their relationship to lupus and autoimmune disease has really exploded in the past 60 years. All right, so let's talk about when you're going to have an anti-Smith antibody checked. So as I said, the anti-Smith antibody is an anti-nuclear antibody. So it's very common to be tested after someone has found they have a positive ANA blood test. So if that test comes back positive, then what we need to do is dig a little deeper. And the way we do that is we then test for a lot more specific autoantibodies. And a lot of our common lab companies that we use will have various different lupus panel tests. And in those lupus panels, they will be testing for various different other, more specific anti-nuclear antibodies. And one of them will be the anti-Smith or anti-SM is how it's listed on your report. And it's the results of those antibodies plus your symptoms plus any other lab abnormalities like anemia or kidney issues, liver issues, whatever. All of that goes into the thought process of the doctor when coming up with a diagnosis. Even though these antibodies are more specific than the ANA, you can't really rely on them to make a diagnosis. The anti-Smith is a little special. Anti-Smith is very specific for lupus. And if you've watched any of my other autoantibody videos, you'll know that I always say none of these tests make a diagnosis, that you always have to take into account someone's symptoms and overall how they're doing and their entire clinical picture, that no one blood test makes a diagnosis. Well, Anti-Smith comes pretty close because it really is so specific for lupus. But as I said earlier, only a quarter of lupus patients will have this particular blood test. So just because you don't have an anti-Smith antibody doesn't mean you don't have lupus. Okay, so now you have your result. How do we use it? How do we interpret it? Well, as I said, because it's so specific for lupus, if someone has a positive anti-Smith antibody, they really do deserve a full evaluation by a rheumatologist if it hasn't already been happening. Something to keep in mind is the anti-Smith antibody is not one of the antibodies that we will repeat. It doesn't go up and down with disease the way double-stranded DNA can or the way complements can. It's really just a positive or negative. So if you've had it done, it doesn't necessarily need to be checked again unless your symptoms really change or a doctor's suspicion of lupus really goes up based on your symptoms. But once it's positive, we just note that it's positive, and once it's negative, we just note that it's negative. Okay, so how does all this information apply to you? As you may or may not know, I am a huge proponent of understanding your own autoimmune condition and its particular flavor. And this is really important when you have lupus because there are so many different flavors of lupus out there. And one of the ways that you're going to get yourself back on that road to health is by understanding your own condition. And some of that is obviously your symptoms and what triggers flares and those kinds of things. But understanding what your labs are is really important as well. Now, the double-stranded DNA and the complements that go up and down with disease are super important to know. But I also think it's important to know what antibodies were present that helped your doctor make the diagnosis in the first place. Now, to be fair, whether or not you have an anti-Smith antibody doesn't really change treatment. It doesn't usually go into your doctor's decision making when they're thinking about what treatments are going to be best for you. But this is a common scenario I see that I don't think a lot of people think about, where understanding what antibodies you had present when you were diagnosed can be very useful. If you find yourself needing to change rheumatologist, for whatever reason, maybe you moved, maybe your insurance changed, maybe you just want a second opinion, it's not uncommon for the new rheumatologist to try to reinvent the wheel. Now, sometimes that's perfectly reasonable and legitimate and maybe why you want a new doctor, but a lot of times it can kind of be a waste of time. So, one of the reasons we do that is if we don't have all the information we need to really understand this person in front of us and the type of lupus that they have. And one of the key pieces of information that can help us quickly understand what you've been dealing with is by understanding, well, how was the lupus diagnosed in the first place? And that includes knowing your autoantibody profile, which includes the anti-Smith antibody. All right, so today we're talking about a very specific blood test, but if you have lupus or any other autoimmune condition, it's a blood test that you are probably very familiar with, and that is complements. We're going to be talking about what they are, what they mean, why we test them, all of it. What are complements? Complements are simply proteins that are found in our plasma, and by plasma I mean our blood. And they are a part of our immune system that can become activated when presented with an antibody or an antigen. Now, what are those words? Well, for better or for worse, I think we've all become very familiar with the word antibody, right? It's a part of our immune system that identifies and then can attach to any foreign material that it finds in our body. And that foreign material is the antigen. Antigen is just a fancy word for foreign material. So when the antigen is floating around and the antibody sees it and identifies it, the antibody goes and attaches to it, and that forms the immune complex. So getting back to complements, when the complement sees this immune complex, it gets activated. And that activation then alerts the rest of the immune system that, hey, something foreign is here and we need to do something about it. And it sets off this cascade, this complement cascade, that then calls out to all the other immune cells to come and like handle this foreign material that's been identified. And it's really an integral part of our immune system. This complement cascade, this complement system is what keeps us healthy against infections. Now, the reason this comes up with autoimmune conditions is there are a number of autoimmune conditions where we know that we can see an abnormal complement level in our blood. And when I say abnormal, what I really mean is low. And there are a number of conditions where this is the case. Conditions such as vasculitis, which really is kind of an umbrella term that covers a whole slew of other conditions, where basically the unifying factor is that there is inflammation in the blood vessels, hence vasculitis. Other conditions such as antiphospholipid syndrome, Sjogren's syndrome, mixed cryoglobulinemia, hemolytic autoimmune anemia, and glomerulonephritis all have low complement levels. Now, I know I just threw out a whole bunch of like technical medical sounding terms, and quite honestly, unless you are dealing with one of those conditions, you most likely have never heard of half the words I just said. But suffice to say that there are a lot of autoimmune conditions where abnormal complement levels or low complement levels are something that happens and that we look for. The most common condition, however, that we associate with low complements is lupus. Talk about testing for low complement levels. It's really two that we test for: C3, complement 3, and C4, complement 4. So lupus. Immunologically speaking, lupus is a condition of immune complex deposition and complement activation. I know, but I just know what I just said is a little much because it is very immune speak. But in the world of rheumatology and immunology, the way we think about lupus is it is a condition of immune complex deposition and complement activation. So what does that mean? We'll break it down. If you remember, I said immune complex is simply that complex of antibody and antigen. Now, it's not just a one-to-one. So you have a floating antigen and all these different antibodies come and attach to it. And that whole mess of proteins is what we call the immune complex. And that immune complex will then go and deposit on a certain tissue or organs within the body. And when we're talking about lupus, that can be the skin, it can be the kidneys, it can be the lungs, etc. Now, why in one individual the immune complexes will go and deposit on the skin or on the kidneys and not on the lungs, or vice versa, we still don't know. There's still a lot we have to learn. But that immune complex will go and deposit on the tissue. And the mere presence of that immune complex then triggers the complement cascade. And all these complements, all these complement proteins come and they do their thing and they go through their cascade, and their cascade then alerts the rest of the immune system to come do its thing. As I kind of jokingly say, it's like calling all the boys to the yard. Like, this complement cascade calls out neutrophils and natural killer cells and macrophages and B cells and T cells and all of these cells that are part of our immune system. And this complement cascade is basically saying, hey, we have an immune complex here, which means we've got foreign material that needs to be handled. And so all these cells come to handle it. And the way they handle it is by causing a lot of inflammation. And so before you know it, this tissue where the immune complex had settled now is super inflamed. And it's that inflammation that we then see as a symptom, or we'll see as like kidney damage or skin inflammation. But behind the scenes, that was all a product of immune complex and complement activation. See? So while all this is going on in the tissues. If you think about it, when we do blood work, what are we testing? We're testing various different levels of things in the blood. When the complement cascade gets triggered, all those complements are kind of going to where those immune complexes are and being triggered, and they're cascading and they're activating and all these fancy words that I could use, but they're out of the blood and they're doing it. There's so much siphoning off of these complements to the tissues that are in question that the liver cannot keep up as produce more complements. So when we check the blood levels of C3 and C4, they're low because they're all being used up in that inflammatory cascade that's happening. So in things like lupus, when someone has active disease or active lupus, or they're in a flare, the C3 and C4 blood levels will be low. Now this is most specific in lupus patients who have kidney disease. So if someone has kidney disease in lupus, they are more likely than not to have complement levels that drop when they're in the midst of a flare or when they have active disease. But it is certainly not 100%. In fact, if you take all lupus patients, not just the kidney disease patients, but all lupus patients, only about 50% of them will have low complements when they're having an active disease or when they're having a flare. But in those patients who have low complements when they have a flare, measuring complement levels can prove to be a useful marker to judge if the lupus is active or quiet. Now, for those of you problem solvers out there, you may be asking, well, if complements are such a big deal in lupus, why aren't there treatments focused on the complements? And that's an excellent question, and one that a lot of researchers who are a lot smarter than me are working on. Yes, there are a lot of different directions that the lupus researchers are going in, like hunting for different targets and therapies for lupus, and the complement system is one of those targets they're looking at. All right, so I know this video was kind of very heavy on the immunology and the physiology, and you might be asking yourself, like, this is all great, like I kind of get it, but like, what does all this mumbo jumbo mean for me? One of the questions I want you to ask yourself and your doctor is, what were your complement levels when you were first diagnosed with lupus? And this is important for a number of reasons. So for the most part, most of us are diagnosed in the midst of a flare. It's when we're having a flare that we have our symptoms that come to the attention of our doctor. And so knowing what your complement levels were in that moment kind of shows us or gives us a clue if you are in that 50% where the complement levels are low, or are you in the 50% where the complement levels are normal in the midst of a flare. Now, it doesn't tell you everything because we need time. Time is going to help show us what our pattern is, but knowing what they were in the beginning is an important clue. All right, so the second thing is, just like I suggested, what do your complements do over time? Now, like I said, 50% of patients will have complements that go up and down when their disease flares and when it's quiet. Only time's going to tell. When your disease became under better control, under whether it was medications or lifestyle or whatever it was, did your complements normalize? Some patients have low complements during flares and have low complements that persist. And there is some controversy within rheumatologists or amongst rheumatologists about what that means, what we should do about it. But the fact of the matter remains, there are some people who feel better, every other marker is better, but yet their complements are still low. And time will tell if that's you. If your complements were normal at diagnosis, it is still worthwhile to follow them and correlate them with how you're feeling. The problem with complements is this: we don't check them when we're healthy. When you go in for your physical exam every year or every 2 years, and you're getting your sugar tested and your cholesterol and like the basics, vitamin D, checking complements is not one of the tests that are done. So the truth is, we don't know what our healthy baseline level of complements are before we get sick. If you look at any lab sheet, any lab result sheet, you have your result and you have what's called a reference range. And that reference range has been determined by a lot of testing and a lot of statistics where they'll say, okay, this is the range that we consider normal in the population. If you look at that reference range with complements, it's pretty wide because healthy people, I don't know why I do that, healthy people can have their complements be through this whole range. So even though when you are first diagnosed with lupus, your complements might fall in the normal range, it can be difficult to ascertain if that's truly your normal or how that would have compared to you before lupus. Does that make sense? And so following what your complements do throughout your course with lupus can still be very telling, even if your complements always just stay within what's considered normal. I am a very big believer and proponent that everyone deserves to participate in their own care and participate in the conversations that are happening about their care. And just having a base understanding of what complements are, why your doctor is even checking them, and what your levels have done over time can really better position you to have more fruitful and productive conversations with your rheumatologist as you talk about next steps to get you to feeling better.
Drug-induced lupus is a specific form of lupus that occurs when a certain medication triggers an autoimmune reaction that then results in lupus-like symptoms. These symptoms will usually start after taking the medication for several months, although it occurs even after being on the medication for years. If drug-induced lupus is being considered, your doc will order blood tests. And although they will order a bunch of tests because, that's what we do, there is one test not usually done that they will order in these circumstances. And that's the anti-histone antibody. The histone antibody is positive in about 95% of drug-induced lupus cases, making it an unusually strong marker for this particular condition. The histone antibody can also be seen in systemic lupus, but it's not positive nearly as often in this type of lupus, so we don't often check it or use it to help us make a diagnosis of systemic lupus. So what is the anti-histone antibody? Well, histones are proteins that help organize our DNA, so they're found in the nucleus of our cell. So you can see how if the target of this antibody, the histone, is found in the nucleus, these antibodies are anti-nuclear antibodies. Thus, people with drug-induced lupus will have a positive ANA, or anti-nuclear antibody. But here's the thing, not everyone with a positive anti-histone antibody has lupus. Some people have low levels without symptoms, so as always, it's not just about the test result, but about your test result in context with your symptoms. Well, what about the other antibodies that we'll often see in lupus, like the anti-double-stranded DNA or the anti-Smith? Well, it's a great question. Interestingly, these antibodies, which are considered classic in systemic lupus, are largely negative in drug-induced lupus. So we have a high suspicion and we check the anti-histone antibody and it comes back positive. What now? Well, we stop the offending medication, maybe start some prednisone or other anti-inflammatory medication, and watch as the symptoms and the antibody levels resolve. In some cases, the symptoms may take longer than we'd like, or they don't resolve at all. In those situations, we may rely on our more typical lupus medications, such as hydroxychloroquine, methotrexate, or azathioprine, but still with an eye on this only being temporary. So as you can see, drug-induced lupus is its own thing. Despite sharing a name and many symptoms of the classic systemic lupus, drug-induced lupus requires a different set of testing and a different approach to treatment. If you find yourself on any of the medications listed and now have new symptoms, ask your doctor if drug-induced lupus should be considered and if you should have your anti-histone antibody checked. If you have had the antibody checked and it has returned positive, discuss with your doctor whether your symptoms match those of drug-induced lupus, as remember, many can have the antibody without having the condition. As I am always reminding everyone within earshot, lab results like these are just one piece of the puzzle when it comes to understanding an autoimmune disease. I hope you found this video helpful. Thanks, and we'll see you next time.